A very good morning to all of you. In last video, I posted ACOG guidelines for the management of pelvic organ prolapse, which I feel was well appreciated by all of you. And as we were planning also, and few of you also suggested that we should now try to discuss the UK guidelines, what the UK says for management of prolapse. And when I was searching the guidelines for the same, I got a surprise. In one of the important guidelines, which many of you might be following, the Green Top guidelines, and reading it for various kinds of exams, I was surprised to know that there are so many topics in those Green Top guidelines which are covered. However, there is no Green Top guideline for pelvic organ prolapse. There is for wall prolapse, post-hysterectomy wall prolapse. However, they don't have any guidelines yet for pelvic organ prolapse. Then I started searching more and I found that nice guidelines are there for pelvic organ prolapse. However, surprisingly, that guideline also is very new, which was incorporated in their system only in the year 2019, which is just 2.5 years ago. They had guidelines for urinary incontinence. However, there was no nice guideline also earlier to 2019 to manage case of pelvic organ prolapse. I don't know what is the reason, but what I can think from here, that urogynecology, again I'm repeating the same thing, is a new field with lot of potential for development at your personal level, professional level, for your patient, for research. So let's join hands together and do something good and great. So today we are going to review the NICE guidelines for pelvic organ prolapse diagnosis and management. This is Ayuga News, which was published on 12th of April 2019. It states that the third version of NICE guidelines, that is National Institute for Health and Clinical Excellence, on the management of urinary incontinence and pelvic organ prolapse in women, was released on 2nd April 2019. Now, important thing here is that it includes pelvic organ prolapse for the first time. The earlier two versions, which were published in 2006 and 2013, only covered urinary incontinence. So the same guideline, which was published in April 2019, we are going to discuss and review today. This is also called as NG 123, which again means NICE guideline number 123. As I have told before, this is a combined guideline which talks about urinary incontinence as well as pelvic organ prolapse. But today, we are going to discuss only that part of the guideline which is concerned and connected with prolapse. Urinary incontinence, we will discuss some other time. For the assessment of POP, they have divided women into three major categories. First one, who present to primary care, who have either symptoms of POP or when you are examining, they are found to have vaginal prolapse on examination. The recommendations for this group is that take history, which includes symptom of prolapse and other related symptoms, do an examination. And here itself you discuss the treatment preferences with her, and if you feel that the patient has significant symptoms and she requires a treatment, refer her to the specialized center. The next group of women are those who come to secondary care for some unrelated problems, and now incidentally, when you talk to them or when you examine them, you find that they are having symptoms or examination findings related to vaginal prolapse. So, the advice here is that refer them to the Center of Expertise for further management. Now, if you are at a specialized center and the patient gets referred to you with the diagnosis of vaginal organ prolapse, what do you do for her? So, you must assess and record the presence and degree of prolapse. You must do a POPQ examination for her, assess the pelvic floor muscle strength for that patient, assess if there are signs of vaginal atrophy, and this guideline very specifically mentions that rule out a pelvic mass or other pathology. As we also tell all the time, prolapse is a quality of life related issues, but when the women come at this stage, we should be very careful that to improve the quality of life, we should not be missing on something which can actually endanger her life. The other important things for the assessment of prolapse are: number one, a validated pelvic floor symptom questionnaire should be used. Routine imaging. For diagnosis of prolapse, it is not required. Clinical examination is more than enough. One more important thing they say here, as we also keep on telling, as was in ACOG guideline also, that if the woman has symptoms of prolapse and you examine her, but the symptoms what the patient says and examination what finding you are getting is not correlating, consider repeating the examination with standing on a squatting posture or at a different time. But the patient's symptoms and your examination must correlate before you plan a management for her. Now, you must investigate this patient if there are these symptoms. Urinary symptoms, if bothersome, before you plan the surgical intervention, you must identify and have a diagnosis. So, if required at the time of prolapse, you can handle this also. Similarly, bowel related symptoms, either related to obstructed defecation, fecal incontinence, need to be investigated thoroughly. If the patient is complaining of pain, please try to find out what is the reason of pain. Usually, prolapse will not cause a lot of pain. A little discomfort because of enterocele and little back pain is common, but if her presenting complaint is pain, please try to thoroughly evaluate her. And again, if you find any symptom which is not explainable by your examination finding of just prolapse, please keep it in mind and try to evaluate it more thoroughly. The treatment always starts with a choice of non-surgical management. So the NICE guidelines specifically say that before you tell about the plan of management, always inquire and discuss about these things: the women's preference, site of prolapse, lifestyle factors, comorbidities including her cognitive and physical impairment, age of the patient, desire for childbearing, previous abdominal or pelvic floor surgeries, and discuss the risk and benefits of all individual management options with her before proceeding and making a final choice about what treatment you are giving to this patient. So, what are the options for non-surgical management of pelvic organ prolapse? First is the lifestyle modification. That includes weight loss, minimizing heavy lifting, and preventing or treating constipation. Second option is estrogen, but it has to be only topical application. It can be given in the form of estrogen creams or estrogen releasing ring. The use of oral or systemic estrogen has not been recommended for management of pelvic organ prolapse. After lifestyle modification and estrogen cream, the third thing we must consider is pelvic floor muscle training or PFMT. So the NICE guidelines specifically state that supervised muscle training for at least 16 weeks should be the first option. Important word here is 16 weeks. So before giving it up, you must tell your women who are suffering with prolapse to try it for 4 months. And mind it, it will work only for stage 1 and stage 2 of pelvic organ prolapse. For greater degrees, usually the evidence doesn't support that pelvic floor muscle training helps. Next management option is the pessary, and vaginal pessary should be offered to women. It can be used in conjunction with supervised pelvic floor muscle training or alone also. Moving on to the surgical management of prolapse. Now, as all the guidelines stated, and all of us know that because of the mesh related complications and FDA warning, there has been a lot of public concern as far as the surgical management of POP is concerned. So, we have to be very careful while discussing this to the patient. Now, they have told all these things that we must tell all the same thing they have repeated, that before you are taking the consent or talking to patient about offering her a surgical management, we must explain the risk of recurrence, we must tell about all the surgical options available as well as the availability of non-surgical options for management of POP also. The very interesting thing which is written in the last line here, it says that role of intraoperative prolapse assessment in deciding the most appropriate surgical procedure should also be informed to the patient. This I also feel very strongly that you must tell the patient that I will examine you again in OT after anesthesia, because sometimes the findings you get there take you by surprise. Tell her that I will do an assessment in the OT once you are under anesthesia, and final management, what all procedure I want to do and what I don't want to do, will be decided in OT. I think this is a very important and relevant point which this NICE guideline has focused upon. One more interesting thing, that when you are giving the options of surgical management to the patient, don't be biased with what you are doing or what your center is doing. Give her all the options, whatever is possible, and if the patient chooses something which you do not do or your center does not do, please refer her to the other center which has the expertise to perform that particular procedure. For all women who are considering surgery for uterine prolapse, discuss the possible complications and lack of long-term evidence on the effectiveness of the procedure. The recurrent rates of these surgeries are high, and tell your patients about it. Though the RCOG has a separate dedicated green top guideline for the management of wall prolapse, but even in this NICE guideline, they have discussed a bit about it. So the options for wall prolapse are vaginal sacrospinous fixation or sacrocolpopexy, which can be done abdominally or laparoscopically with mesh. Mind it that there is, in this guideline also, there is no mention of new procedures like laparoscopic pectopexy. So if you are offering that to the patient, be careful, because it is not a part of the guidelines yet. Last time also we discussed this topic a bit. What about colpoclysis? So the NICE guidelines recommend colpoclysis for uterine prolapse as well as for wall prolapse. This should be offered to women who are no more sexually active and have high risk of operative and postoperative complications. So that's it. Hope it helps you a bit more clearly in conceptualizing the management points and making a straightforward decision for your patient. Thank you.